because that person had not had an opportunity to indicate their wishes, and the family members and the health team were all left basically with the default. And the default is we do everything we can as long as we can until there are no options left. Oftentimes I felt that we were actually prolonging a patient's dying. We were not actually improving their living or their quality of life, but just causing a much more protracted and difficult period of suffering, not just for the patient themselves. Often they were not conscious or aware of what was going on, but particularly for family members who would visit, who would hold out hopes that their loved one might improve when everyone knew that the chances were indeed quite remote. And so we thought today this session would be a little bit different, particularly in the time of COVID. We know that people can fall ill fairly quickly, and they can also deteriorate fairly quickly. And when they do deteriorate, and if they were to end up on a ventilator, then oftentimes once a person's on a ventilator, we also use drugs to sedate the person so they're more comfortable. But then that takes away their opportunity to engage in a meaningful conversation or to have a really reasoned decision-making process with the patient. And so once that happens, once you cross that line, you can't go back and have the conversation. So unless it's been done in advance, unless you've indicated to your loved ones or in writing, then we're back to that default of doing everything for as long as possible. I'll just share a really quick story of a patient that I cared for. I'll call him Norman. And Norman was in his 60s when he was having more trouble with his lungs, having a great deal of difficulty breathing. And I knew that his time was probably limited, but I wasn't sure how long he would have. And I decided to take the time when he came to visit in the clinic to make sure that we had a conversation about his wishes at the end of life. And I said, Norman, if you were to get sick and couldn't speak for yourself, what would you prefer? Would you like us to put you on a ventilator? Yes, he said. Would you like us to continue that indefinitely? Oh, no, he said. You know, if the ventilator would help me to recover so that I could go back home and be with my family after a few days or at most a few weeks, then by all means, go ahead and do that. But if it doesn't look like I'll recover, if it doesn't look like I'll be able to go fishing, which he loved, or play with my grandchildren, which he loved, he said, certainly, why would I want to stay alive on a machine? And so we had the conversation, we completed the documents for his advanced directives, and I even, in my medical note, I put quotation marks around his very words that he used to explain to me what he wanted and what he didn't want. And sure enough, a few months later, Norman ended up in the hospital. He was getting worse, and he ended up on the ventilator. And he had been on a ventilator for about 10 days when we decided the chances of him coming off the ventilator were very, very low to zero, and that we should conduct a family meeting. And Norman had 7 children, several of which lived out of town and had come back for this family meeting. And the family meeting included a group of about 15 people in the room to discuss the best next steps. And I remember that there were 2 children that were very adamant and very insistent that everything had to be done for their father as long as possible because they loved their father and they didn't want to give up on him. His wife, on the other hand, who sat weeping through most of the visit, said that she knew that Norman would not want to live like this indefinitely. And as we explained, his chances of recovery were so low, I pulled out the note that I had printed off so that I could share the words of Norman with his family that were gathered together. And as I read what he had written, what he had told me about his love of his family, his love of his grandchildren and fishing, I explained to the family that I thought that the chances of him actually being able to do those things he loved were almost zero. They were all then able to make the decision together to end life support. And we did indeed discontinue the ventilator, and Norman died peacefully, surrounded by his loving family. So that was just one of many, probably hundreds of examples that I have of patients that I've cared for. But had I not had that conversation, this situation where there was a disagreement in the family about what to do, what not to do, could have gone on for weeks, months, or even years. And so I share that as a reminder that it's important to have the conversations, to put these wishes in writing, so that if the time comes, your loved ones and your health professionals are not left guessing about what you would want. So I wanted to share that to get us started. Shara has a lot of examples, a lot of experience in this regard, having these kinds of conversations with her patients. And so I encourage her to share some more information. And then we wanted to save the majority of this session really for discussion with you. So there'll be ample time for question and answer. And I hope someone is managing the chat line, which I can't really see on my phone very effectively. And we hope that we'll have time for real live discussion, because this is not an easy conversation. It's one that many of us would rather put off and not think about, but it's so important that we have it. And once we have it, I think it gives all of us a peace of mind.
Thank you, Cindy. So yeah, Cindy and I come from a medical family, so we have these medical conversations often. We probably talk about death and dying more than more than the average family. But when we get together, we do check in. And with COVID, we've had this discussion about, would we want to be on a ventilator? Would we want to be hospitalized even? Would we, what would we want? So things can change, and opinions can change, and your own beliefs can change as more information becomes available. But I've put in the chat feature a lot of the resources that I like to promote. One that I sent with the original invite was Caring Conversations. And that's just a workbook to how to start this conversation with your loved ones. And some people just aren't ready. Some people take a long time. Sometimes they get families together and some of the family is willing to talk about it. Some of them just absolutely refuse and just, run sobbing out of the room. But what I would always do with my clients was try to get them to articulate their wishes. Just kind of say them out loud, pose a couple scenarios. What if this, or what if that? And let them think about it. And sometimes it's a very delicate topic, and sometimes it takes a long time for people to be able to actually say it or even think about it. What really helped me a few years ago here in Louisville, Kentucky, we started what's called a Before I Die festival. And it was a whole month-long conversation. In the month of October, they made it around Halloween and Day of the Dead. But it was a whole month-long event where they would have what's called death cafes. And I know they have them there in Orange County. A lot of hospice organizations try to get people having this discussion about death and dying, before it's too late. But the whole month long, there would be art installations, there would be meetups just to have conversations. They would have drink to the death and meet up at a pub and talk about death. They would meet at the crematory to see that process. They would meet at the mortician school to see that process. And just to have people come together that are comfortable talking about it to get the conversation started. So I've put one of those resources in, the Death Cafe, and I really enjoyed being a part of that month-long event. Yeah, we would tour the cemetery. There would be cemetery tours and just all sorts of things. And it was kind of lighthearted, but very deep also. I guess I did the most soul searching and deep work when I came across the book by Atul Gawande called Being Mortal. And I read this book right at the time that I had an autistic patient that he must have been in his 30s, but he had been in and out of the hospital like 10 times in the past few months before I got him. One organ failure after another after another. He couldn't articulate his wishes. And he had family that, were doing the best they could, but I had to help them think through what would their brother Bobby want, and what would we want if we were in Bobby's shoes. So I came across the book Being Mortal. There's a lot of there's a documentary, a PBS documentary. I've put that in the chat box, a link for that. The book, it's a very hard read. I cried most of the way through it, and it took me a long time to read it because I would break down many times just trying to do this deep soul searching work while I was thinking about my patients and what they're going through. So I would highly suggest that if you're interested. Atul Gawande was a surgeon who decided to get out of surgery and become a writer for the New York Times because he found himself doing a lot of surgeries on people that he knew. He was an oncology surgeon, I believe. He knew the ultimate, it was just putting off inevitable, and that his patients would suffer from doing some of these procedures and some of these chemotherapies and surgeries and so forth. So that's a really great resource, is Being Mortal. There's a lot of interviews with the doctor and good information there. So as far as advanced directives go, what I have done personally is 5 wishes. And this is a workbook. There's a couple different workbooks I've put in the resource list. One is called Caring Conversations, and one's called 5 Wishes. But they basically will serve as advanced directives if you fill them out and have them notarized or witnessed. So I'll show you what it looks like. This is the 5 Wishes document. And these are my wishes for, you can see there's 5 wishes. And you go through it. What I would always tell my patients is to first go through and just read it. Just read it in its entirety and put it aside. And then think about it. And then talk with your family about it. And then fill it out. Filling it out is the last step. But once you fill it out and sign it with the witnesses, that's your advanced directive. That is an advanced directive. The state of California does have a form that's kind of, in my opinion, these state forms are kind of lame. They're not very detailed. They're just like, it all kind of started when people were getting cancer, and it was, some of these living wills just say whether or not you want to be on artificial nutrition. Well, we know that's not what takes people these days. It used to be when people were getting cancer, and that was a major cause of death. The artificial nutrition would keep them going, but now there's artificial ventilation, there's kidney dialysis, that's basically artificial kidney work. There's all sorts of treatments that prolong life that some of these other workbooks will go into more detail instead of these state forms. California does have a state form. I think Cindy filled it out. And Cindy had some challenges filling it out. She can tell you when we get back to her. So that's what a living will and advanced directive is. It's pretty much just you articulate your wishes, you have it witnessed. It's a good idea to name 2 different healthcare representatives, because like I have Cindy listed as my representative, but if she and I are in an accident together, she can't speak for me. So it's always good to have a second representative. Some people even have more. and make sure the whole family knows about it and that the family doctor knows about it. And this is a great opportunity is during the annual wellness exam to talk about it with your doctor. Talk about the advanced directives. Talk about your wishes. Um, I'm sure Cindy has many of these conversations with her clients because we know how important it is.
So that's really a great overview, and I think those are the basic forms that we need. You know, some type of advanced directive and some type of healthcare power of attorney designation, right? So those two things, if you do those two things, then you're pretty well set. And the, you know, as Shara has described, first thinking it through, what's important to you, and then having the conversation with your loved ones, certainly with the people that are designated as your power of attorney for decision making. And I think some people get confused because there's lots of different types of kind of end of life planning. Some of them are
Terminology.
financial, some are legal, some are health related, some are not. And so, so I think some people, when they say, well, I have a will, you know, I've made a will. Well, a will is generally to pass on your physical possessions, right? Your wealth, if any accumulated assets, but it's not about your body, right? You're keeping yourself alive. So I think it's important to distinguish between the legal financial issues at end of life versus the healthcare issues, which is what we're focusing on now. And and the other thing I say that's important is, besides making sure that your designated decision maker has it, you make sure that it's also in your medical record. And so in order to get it into your medical record, that means you've got to bring it up with your doctor or nurse practitioner or whoever is your primary health professional. They should have it indicated in your medical record so that if you ended up in the hospital, that would be, now these days with electronic records, it should be available. Um, on the other hand, if you're traveling and you ended up in a different hospital than your home base, they may not have access to those documents. So then you've got to make sure that your designated decision maker, they should have a copy of it. You know, everybody should have a copy of it. And if you change it, if you update it, make sure that all of those sites get updated so that they have the most recent information. And none of this decision making is irrevocable. You can always change your mind as long as you're conscious and aware and able to make that decision. But oftentimes I've cared for patients who, you know, you have a situation in which, are they really competent to make a decision? Because they may be kind of lapsing in and out of consciousness, and you're not quite sure how much the patient is really grasping or understanding of the complexity of their situation when they're very ill. And so oftentimes, you know, once a person gets really sick, it's really hard to change these documents because competency comes into question. If they're on a lot of medication, or if they're really sick or hypoxic, they're not thinking clearly. And so then you go with, you know, the most recent documentation. And if there's no documentation, again, the default is we just keep doing everything as long as possible. So that may be enough for us to kind of set the table, and maybe we could hear some questions or comments.
Cindy, I'd like to talk a little bit about some of this terminology because sometimes people get really confused.
Okay.
So what I just described is a basic living will. Okay, sometimes it's called advanced directive, but that's just a basic living will where you get it notarized. You can do it yourself. You get it notarized or with two witnesses. Okay, and in the living will, you name either sometimes it's called a healthcare representative, sometimes it's called a healthcare agent. Okay, but that's where you're naming somebody to be your voice if you don't have a voice. So a power of attorney is a slightly different document. And so I've also personally, I have what's called a durable general and healthcare power of attorney. And this is usually developed by an attorney, although there are forms on LegalZoom and you could probably find a way to do your own. The healthcare power of attorney gives more authority to handle all affairs, okay, not just health, but also financial. To hire people, hire staff, fire staff, all sorts. So it's a good idea also, I think, for most adults to have what's called a financial and healthcare power of attorney. Sometimes it's called a durable general and healthcare power of attorney. There might be different terminology for different states. An additional document that you might hear about is called POLST, P-O-L-S-T, and I've put a link to this form in the chat box, and it's Physician Order for Life-Sustaining Treatment. So this document would be done if someone has some seriously advanced illness, and there's some very technical, detailed healthcare decisions to be made, and they know that those decisions are going to be made. Which it may say, if I develop pneumonia, treat me for pneumonia. Go ahead and give me IV antibiotics. Or it may say, if I need dialysis, go ahead and put me on kidney dialysis, or don't. These are the kind of things that aren't in a basic living will, okay? But these are for people that say they have cancer or they have some end-stage disease that they know is terminal. They can drill down a little bit more in the POLST form to get their wishes, but the POLST form will not stand alone as a living will. What else? Is there another document? No.
Well, so I'll bring up, there's a few terms that I think people also get confused about: no code, no intubation.
Oh, DNR. Yeah, let's talk about DNR. Let me give a little overview about. So do not resuscitate is a separate order, and in most states you have to have the notarized state form. And I've also put this in the chat box. So if so DNR only comes into play if the heart and lungs have stopped and they need CPR. Okay, that's all it means. Resuscitate or don't. Either do the CPR and intubate and start the the mechanical respiration, or don't. But some people feel strongly about this. If somebody's in their, older years, in their 80s or 90s, we know that CPR is probably going to do more harm than good. It may revive them to the point that they may have a little more time, but the time, it's traumatic to do CPR on an elderly person. And in the state of Indiana and Kentucky, if an EMS is called, if 911 gets called and they show up in the home, if they don't see that form prominently posted, they have to do CPR on the way to the hospital. It's the law. They have to do it. So if someone really does not want, and this is only if your heart and lungs stop, so you're clinically dying, you're going to die within minutes unless CPR is done. Everything's stopped. Whether they want CPR or not. So I do know some people my age that say, no, we want nature to take its course. Even though they're healthy, they say, no, if my heart and lungs stop, don't do CPR on me. Not everybody wants CPR. So that's another consideration to really think about and make. Would you want that to happen? So that's either you're a full code, which means do everything in the event of emergency, do the CPR, put in the tube to start the mechanical ventilation, get the heart and lungs working again. That's full code. Or DNR means do not resuscitate. It means if my heart and lungs stop, don't do CPR. Is there more to that, Cindy?
Well, right. And then there's other variations on this. Like in some cases, we would have patients that said, okay, they want to be full code, resuscitated if their heart stops, but they don't want to be intubated. They don't want to breathe
on the POLST form. So that's where you would designate that. I had a client that was that way. He said, don't ever put me on a breathing machine, but go ahead and do CPR.
That's right.
That's the kind of things that would be on the POLST form, which I guess
right.
you could write in some of this stuff on a regular advanced directive. I'm sorry we have to have so many forms.
I wish there was a national
We
form
need
that
just
would
one
make this
form.
so simple, right?
Need it.
But there, it's not like that. So you have to kind of deal with whatever is your health system, but and your state laws. But I think that that's where a lot of people get hung up and not and wondering. Uh, but I think that's enough of these various terms and forms for now. Let's see if we have some questions.
Okay.
So I left a question in the chat, but I don't know that it's necessarily clear.
Oh, it is a great question. Yes. And actually, that's a good question. So what I would do personally, what I would recommend is that you digitize, you do one of the advanced directives and you email it to your loved one and yourself so that you have a digital copy of it. Actually, in the 5 wishes, there is a little wallet card right here that says you can put in your wallet that says I've got this.
Mm-hmm.
So yeah, I would digitize it because usually a copy of this is as good as the original, and then I would keep the original with your vital documents at home, and know where they are. Know where you can tell people where to access them.
But
Right.
I'm wondering though, maybe this is a question for Cindy. As a practitioner, if somebody comes in for whatever problem, they begin this process, or their heart stops, they're dying. Do you rifle through their pocketbook or wallet in search of this to see in the moment, or how would it work in practice?
Right, right. Well, so most of the time when a patient comes in, there is an emergency contact that's designated. And most of the time, the emergency contact is the person who's also designated as the healthcare power of attorney. We don't generally go rifling through people's pocketbooks or whatever wallets looking for these documents. If we don't have them, then we basically err on the side of doing everything. And oftentimes, like back when I used to work in the emergency department, and we would have patients would be brought in as what we would call pulseless non-breather. So they're not breathing and they don't have a pulse. And if they were found down and unaccompanied, basically we would do everything we could to try to, resuscitate them or bring them back. And only after a period of time that it became clear that they weren't resuscitatable, then we would stop. But in the meantime, we would be looking for any possible information that they may have on them of an emergency contact. So now in the phones, in our smartphones these days, you can designate an emergency contact that I think most smartphones, you can access the emergency contact and reach that person even if you don't have the code to unlock the phone for security purposes. So I think having that emergency contact is important.
I will say that EMS, I work with them a lot at public events, and they will go to the phone if there's a individual that doesn't have anybody with them. They'll go to the phone and look for the health app to get vital information. So I would encourage everybody to fill out their vital information on their health app.
So
Thank you. That was really helpful.
Sorry, yeah, it was. What I think I hear you saying is, in addition to the phone and in addition to digitizing it, it's really important for me to let my doctor know who those emergency contacts are and what my wishes are. Mm-hmm. So I'm getting those documents together. I want to be getting those documents together for my own doc as well, right?
Mm-hmm. That's right. And I think that, physicians are often really busy trying to cover lots of ground in a visit in a short period of time. And I say we're guilty of not initiating these discussions as we should be. We had a big initiative in Wisconsin to try to do this statewide. And at the time we started, we found that only 5% of people across the state had any kind of designation. And then we brought it up in some communities up to 80 or 90% for patients that were 50 and older. So we tried to emphasize kind of older age, although you could argue that this could happen at any age. You know, for minors, obviously the parent is the emergency contact, but for adults, you know, the frequency just increases the older you get. And so where do you put this? But I think that don't feel shy to initiate the discussion with your health professional and to say, I've completed my advanced directives. I'd like to make sure you have that in the record, which I did for my own doctor when I moved here to California. Everything was in Wisconsin. And so one of the first things I did with my doctor here is to say, I want to make sure you have a copy of my advanced directives and my emergency contacts.
That's
And
helpful.
you can easily upload them, and if you're on a portal with your doctor's office, you can just upload them. And you know, once it's digitized, it's there.
Yeah, most places around here are using Epic. And Epic, if you go onto my chart, you can upload documents in there. And so you can simply upload them, which is what I did for my health directives.
And I'll just say what I like to do with my will, my personal will and power of attorney. I like to have it in the Word format so that I can change it at any time if I need to. But if I'm going to send it along to somebody else, I put it in PDF format. I convert it to PDF so it can't be altered. But I'm always having a copy that, you know, we need to change it, we can.
So I see a question from Margaret about, would these documents be valid in other countries if written and notarized in the US? It really depends. It really depends on the other country that you're in, maybe or maybe not. And so I think if you're planning any kind of extensive travel and have health concerns, you may want to explore that in advance and think about where you might get medical care when you're traveling. I've done a lot of global health work and lived abroad, and I always made sure that I had my medical evacuation insurance and so forth. All of that was kind of aligned with my designated healthcare decision makers, so they would know if I was abroad and something was to happen, what to do, what not to do.
That's a great question. Thanks. That's great information too.
Of course, these days, none of us are traveling much. Right?
Would you also recommend, so for example, my healthcare insurance through Kaiser Permanente, they have an electronic medical record that goes across all providers, all facilities within their network. So, you know, it would seem to be relatively easy for me to make them aware in the profile of my wishes, so that if I show up at a facility, they, you know, they're naturally going to bring up my profile. So is that something that you'd recommend for people like me? And is there anything similar that could be done for people who don't have an integrated system like Kaiser's?
Right, and that's where the problem lies. So certainly within Kaiser, I would think that you could upload, and you know, if you were to fall ill or to receive care from any Kaiser facility, that would be available. But if you ended up somehow, you know, after an accident, it being taken to a non-Kaiser facility, they would not have that documentation. And again, this is where you have to have your designated emergency contact who has a copy of it, who could bring it in, okay?
Mm-hmm.
Or who could send it along electronically. Oftentimes these forms can be sent by email or by fax, and they're considered, you know, as long as they look like they've been kind of legitimized, we honor those forms and the emergency contact sending that information. And we're always really grateful if we can get that information.
So Cindy, I understand what my responsibility is to let my family members know what I want. But what about those family members that we have that are may or may not be doing well? and we haven't asked those questions, or we've asked those questions and we're not getting good answers. In my case, someone with advanced alcoholism. How do you handle those situations?
Yeah. Yeah. Shara, do you want to take that one?
Well, I'll say my last client that I had in California, he didn't have advanced directives and he didn't want to make them. He said when the time comes, his family can figure it out. He didn't want to think about it. He didn't want to talk about it. Very powerful man that had very high intelligence, very religious, but he just didn't want to talk about it or think about it. And unfortunately, some people won't or don't want to. So then in the emergency, that's when that really tough conversation needs to happen with the physician and the family that's there to advocate for the person to help figure it out. But that's what we're trying to prevent is, you know, these last minute emergency decisions. We're trying to prevent that, but some people just won't. They won't talk about it. I know you also mentioned and had the question about people who live alone or have no family members. And I've had many of those clients also. And what we've done is we've identified a church member or a good lifelong friend or a neighbor. Sometimes it has to be the next door neighbor to serve as their healthcare representative. Sometimes it's their personal attorney. But that does come up. I've had many elderly clients that had never had children and had outlived their entire family. There are some agencies that might be able to be hired. The agency that I worked for here in Indiana could be a healthcare power of attorney, not financial, which you can hire people to do the fiduciary part if somebody's not able to do their own finances. But you might be able to identify if somebody has absolutely no one that's willing to serve in this role, which it's a tall order. If you're going to be a healthcare power of attorney, it's kind of a big obligation and responsibility that some people just don't want to take on for a non-relative. So sometimes there are agencies that could be hired. Unfortunately, sometimes people have to go into what's called guardianship, where the state kind of takes over and appoints somebody to manage their health and financial. And we try to avoid that whenever possible here. So we have had to tap into the church or the neighborhood or friends to get somebody to step up. A great niece. One of my clients had a great niece that said, I'll do it. So sometimes you got to look kind of hard, but most people have somebody that's willing to, you know, look out for them in the event of an emergency, if you look hard enough. Sometimes they don't have anybody, and that's sad, but that happens sometimes.
So I just saw a message in the chat, a question about what are the documents we need in California. So Carol, there is an advanced healthcare directive form that is available online for free from the state of California. And you just put California Advanced Healthcare Directive form. That's what it is. And it basically, it's a 7-page form. It allows you to designate your agent and optional agents, backup agents. I think you can list 2 or 3 or 4 different people. It tells about instructions for healthcare. It's pretty straightforward. It says not to prolong life or to prolong life. Okay, those are the choices, right?
Yeah, that's why I don't like these state forms.
Yeah, but it's better than not having a form, I'll tell you that. And relief from pain, okay?
But that's what I've seen, and actually I have one and my mom has one, but you were listing all these other forms, and the question is whether we need, well, 2 questions, whether that's specific enough and whether there are additional forms that are needed.
Right. Well, so this form does include an area for other wishes. And so if you look on the form, I'm looking at the form now, and it has other wishes. You can write your own. So here's where you need to write in. And so, for example, like in this time of COVID, we know that if you end up on a ventilator, there's about, at least from the data that we're looking at across the country, for those who end up on a ventilator, depending on their situation, there may be a 50-50 chance that they're going to make it, right?
Right.
Okay. And so then do you want to say, okay, prolong life, but I don't want to be on a ventilator for more than a month, right? Or more than 2 weeks or something like that. You could make it arbitrary, whatever you feel comfortable with. A physician colleague at UCLA, he shows a picture of a squirrel, and the squirrel like gathering nuts and running up and down a tree. And he's like, what is it? What's your nut? What's the thing important in your life, like that squirrel, that if you can't run up and down trees, you don't want to keep on living, right? And so for me, it's like, if I'm not consciously aware and I can't interact with my surroundings, why would I want to be kept alive on machines indefinitely? And so I've indicated that do not continue life prolonging support if I'm not conscious and there's remote chance of improvement, right? I don't want to live like that and be a burden on my family or resources. So you can write in your specific requests, and then you're done. You're done right there. And it has a witness requirement, but it's it's a 7-page form. It's pretty straightforward. Really, that's all you need. That's all. But you just have to make sure that your wishes are clear, because this checkbox of prolong life, don't prolong life.
That's what they all do, and it's so vague.
Yeah, it doesn't really give much substance to it, right?
Okay.
That's
Yeah.
why I personally prefer the workbooks. And it says right here that this is, it meets the state requirements under California law, the 5 wishes. But what you could do is read the 5 wishes. It's free online, and figure out what to write in on that California state form. I think Cindy did the California state form.
I
Cindy,
did.
remember,
Yeah.
tell us about your experience with that state form. Do you remember?
Well, right. I mean, it was just a little bit, I had to take what I'd done in Wisconsin and try to translate it over here. And then I had to get it witnessed, and they want a witness that's not the same as your designee. So whoever's your healthcare power of attorney should not be the witness. You have to find someone else to be the witness.
You can't have blood relatives witness. No blood relatives.
Yeah, it
Which
says.
is what messed us up, Cindy, because I was your healthcare, one of your agent. Well, I was your blood witness.
Yeah. Well, then I got some other random people to sign as witnesses, right? And so, yeah. And then you can have, if you're in a nursing home or some other facility, you can have the social worker or a nurse, a health professional, sign the form as well. So you can have others, but and then it's a matter of getting a copy of that and then making sure that everybody has it, including your physician. That's all. It's really not that hard, but it was a bit of a nuisance. Yeah.
Well, but you also mentioned the DNR, and I'm wondering whether as an additional form, whether that's needed, or if not, whether my 6-year-old mother should, in addition to the advanced directive, have a DNR hanging on her doorpost, or her wishes on that. That's what I'm wondering, because you mentioned all these other additional documents.
Yeah, it's unfortunate that it's not all rolled into one, which the Pulse tries to do it, but so I don't know about California. You might want to check with the EMS provider. You may just want to call the local ambulance service and ask them what form is needed. Will the post suffice? Because in some states, the post has a place for DNR, but I've heard, like in Indiana and Kentucky, one state will accept that, one won't. One wants the standalone DNR form. posted permanently.
And the other thing I did with my patients who did not want to be resuscitated, once that was really clear, and if they were living alone in particular, we would get one of those medical bracelets, those medic alerts that they would wear either a necklace around their neck or on their wrist. And it would say, do not resuscitate right there. Because in the hospital, that's what we do immediately when patients come in. You know, we put on their ID bracelet, and then we put on a separate bracelet if they are DNR. But for people who live home alone, who say they were found down, no one would know, where would they look? We would just have them wear those bracelets or necklaces just so they wouldn't get resuscitated accidentally. And we had a situation of a patient who had clearly indicated that they were DNR. And unfortunately, they were resuscitated, they were brought in, and they were basically ended up living in a kind of comatose state for many weeks until we were able to finally sort out the DNR was so clear cut that we were able to withdraw life support. But that was a lot of, you know, really wasted effort just because we couldn't find the form right away or any indication.
The refrigerator, I know, is a go-to spot for this. They're going to look on the fridge.
Carol, did that help you?
Yes, thank you. I would share that this issue of who's allowed to sign the advance directive is interesting. A year or so ago, my husband landed in the ER and we had to get some things signed, but none of the medical personnel there could do it. I couldn't do it. We basically ended up having to ask the person who was accompanying a different patient in the ER because the ambulance guys couldn't do it. Nobody who had any kind of financial relationship with the ambulance, the medical facility, anything like that could sign it as a witness. So yeah, I just caution people that's, if you find yourself in the ER, it's going to be tough to get it signed then.
Yeah, yeah.
It's a shame they didn't have a notary right then and there.
Yeah, right in the ER, right. Okay. Thank you very much. Thank you.
Are there other questions? Margaret, did you had a question?
Here's one about DNR. About DNR, isn't it possible that some may benefit from mild resuscitation, no need to break their sternum? Others need harsher procedure. Can one's DNR be a little nuanced? No, it's either CPR or no CPR with the DNR, but then with the pulsed, that's where you can get into these nuances. You can say, give me rescue breathing, but don't give me compressions, I guess.
Yeah, or no intubation, or give me drugs, but don't put me on a ventilator. You know, you can designate those kinds of things. The challenge is it's hard to think through all the potential scenarios that are just kind of infinitely variable. So I think the more you're kind of straightforward and simple with it, and, you know, just realizing that health professionals in an emergency situation, it's either yes or no. It's, you know, you can't halfway do a code. Although, you know, a lot of us in the hospital would say, well, if this patient codes, we're going to walk very slowly instead of run, because we know that doing chest compressions on this patient is really not going to have any positive benefit, and it's only going to be difficult. I mean, torment them. And yeah, so we don't enjoy trying to resuscitate people that we know the chances are very, very, very low.
But now I think in the age of COVID, and this is varying across the US too, but there's, they have what's called an allocation of scarce resources. So sometimes the doctors have to make these decisions based on, you know, and with COVID, they don't prefer to do CPR on an elderly person. Cindy, you can talk a little bit about that.
That's right. I mean, we've actually had discussions within the health system about, is it even ethical to code a patient who's, you know, say a patient is already intubated on a ventilator and their heart stops, would you call a code on that patient who has severe COVID disease? And we know, first of all, that the chances of being able to resuscitate them is very, very, very low. And number two, the chance of exposing other health professionals to getting contaminated themselves is very high. And so then you've got a kind of an ethical paradox of, should you even try to perform CPR on a patient with severe COVID disease and expose a lot of health professionals? Because usually in a code situation in the hospital, there's usually 6 to 10 of us in the room, and there's a lot of respiratory droplets everywhere. And so we're all exposed. Obviously, we would be gowned up and so forth, but it's still an exposure, most likely.
So you've moved into an entirely new ethical territory.
Yeah.
Well, this is, it is now 5:01 and we've committed to an hour. I would ask if there's any last questions or any last things, Shara or Cindy, that you want to share.
Molly has something.
I just want to say thank you both very much for doing this. I am one of those people who has not completed this. I read Atul Gawande and it inspired me to do it, but I didn't. And so I'm grateful for this next push. And I have one sort of COVID era specific question. So you quoted the statistic that 50% of people who go onto a ventilator come off of a ventilator. But if you get into that territory of, yes, maybe I'm willing to be put on a ventilator, but how would you, is there information, do we know enough at this point about who might recover in that situation to be able to say something specifically about that?
Right. Right. Well, it's kind of hard. And, that 50% is it's a very rough average. And it really varies quite a bit. For instance, a young, healthy person who goes on a ventilator has a much higher probability of surviving and coming off of it than, a 95-year-old who already has heart and lung problems, right? And so there are what we call comorbidities, other kinds of illnesses that a person might have that would either increase their risk of complications or of full recovery, decrease their risk, of severe complications. So, we kind of look at a lot of different signals like how's the heart doing, how are the kidneys doing, et cetera, et cetera. And once you get into multi-organ system failure, the chance of a person recovering it becomes less and less the more organ systems that are involved, right? If it's just the lungs and everything else is pretty good, then you may be able to pull through. We're just starting to see data now from people who have been on ventilators, for a month or more with COVID. And those patients have a much longer and more protracted period of recovery. And oftentimes, a lot of those patients will also have pretty substantial neurocognitive impairment as well. And so
one could say, if I'm in a situation where I'm starting to have multiple organ failures, that's it. Take me off.
I mean that the more organs involved that are failing, the less likelihood of recovery. We can say that. And so, again, part of the challenge too is once a patient's in an ICU, they usually have a different doctor for every organ system. And so back when I used to work in the ICU, the kidney doctor would come, the lung doctor, the heart doctor, the infectious disease doctor, they all had their own area that they were focusing in on, but they weren't looking at the big picture. And as a family doctor, I would often say, okay, well, you might be able to keep the heart beating, but if the lungs aren't working, or if the kidneys now shutting down, you know, so it takes a fair amount of sophistication or honesty to look at that big picture. And oftentimes family members are not really well prepared to do that. And oftentimes even within the health system, because you have a different doctor for each organ, you know, you sometimes don't have someone taking that big picture view.
That's when you might want to think about a geriatric care manager to help.
Yes.
Or call Cindy. Call a family doctor. Yeah, unfortunately, these doctors don't talk to each other in the hospital. They make cryptic notes that they may or may not be able to read.
Yeah, I've seen that myself. And then as long as I'm here, I just want to ask Shara. So I do see your last two notes in the text, but the first ones you said you were putting there, I don't see. I wonder if other people are seeing them.
I didn't see them either. I was actually asking Zach if he saw them.
It says read to everyone. I started at 6:50, so if you scroll up.
Yeah, I didn't see it.
So Shara, maybe what we could do is after the fact, we could just send out an email with all of these resources on it. I'd be happy to work with you to we can compile a list of resources and say, we talked about these.
I think that'd be really helpful. Thanks, Zach.
Sorry, I meant to paste something else, but I was trying to copy the DNR forms that Shara had put in the meeting at the very beginning. So, but I think Cindy's suggestion is a better one, to put it in an email, because as soon as we log off, this will disappear.
That's right.
Yeah.
Okay.
Yeah. So we'll just send a follow-up email with links to some of these key sites that we've mentioned. And, you know, I just would say in closing, I'm so glad to have the chance to have this conversation and the really great questions that have been brought up. And we're resources for the community. So if we can be of further help, let us know. And again, I want to thank Zach and Susan and Hobart and everyone for facilitating these discussions. I think they've really been a great source of support for me and for the community.
Cindy, thank you. And Shara, thank you. You are tremendous resources. And
yeah, and
happy to do it.
Thank you. And I would watch you guys anytime to what was also happening this hour in Oklahoma.
Oh my gosh. Yeah, let's not even
talk about death and dying instead, right?
Exactly. That says a lot.
Okay. Thank you, everyone. Have a great rest of your weekend.
Thanks.
Thank you.
Bye.
Bye.